even describe in words the honor it is to be invited to the kingdom to give a talk to your society. There's really too many of my friends and originally my trainees and my colleagues to thank all of them, but I do have to have a special shout out to Dr. Emil for inviting me and for my personal chauffeur, Dr. Al-Katabi, over the last couple of days. So today's talk is something that we do a little bit more at Western than some places, but there's an emerging literature in this area. It's an area that some people may want to take advantage of, but I think it's another aspect that even if you do not use personalized medicine on a regular basis, it gives us a way of understanding and conceptualizing why some of our patients do well and some do not do well. So these are my speaker disclosures, these are objectives. So today what we're going to do is have a bit of a better understanding of the potential causes of complications of immunomodulatory therapy in IBD. We're going to be able to predict who's at risk of secondary loss of response, and we're going to talk a little bit about the role of genetic testing. Now, if anyone was in Stockholm a few months ago for ECHO, they may recognize this picture. This is a ship called the Vasa, and I'm not just putting it up because it's a pretty picture and because it shows off that I was a little bit further back. I'm sorry? Close up to the mic. Oh, get closer. Sorry. This is a picture of the ship called the Vasa, and I think the Vasa has some relevance here. This is a ship that was built about 500 years ago by the King of Sweden. He wanted to dominate the Baltic Sea. He built this massive ship with 500 sailors, almost 100 cannons. The ship was launched, promptly went 300 meters into the bay and sunk to the bottom. And so it's a good example of doing your homework ahead of time because certainly we don't want our patients to start on an advanced therapy and promptly sink and not do well. So I thought I'd start with probably just a quick review of the first paper that was actually presented at ECHO by Dr. Noor. I actually saw him present this as well in Korea a few weeks ago. It was very well received, and this has now been published. And basically, it was a paper that was designed to find out which patients should be treated early. We've all heard of top-down, step-up therapy, and I think most of us now are being more aggressive and considering more top-down approaches. The original concept of this study was actually to see if there was a group of patients that could officially be that you could identify for early early top-down therapy. Essentially, what they did was they started patients on either immunomodulator with Imuran or methotrexate, along with infliximab, or they had a second group where they started with steroids and just used the accelerated therapy when necessary. And what they found, and not surprisingly but incredibly impressively, was that step-down therapy was markedly inferior to top-down therapy in terms of patient outcome over the next year. So treating our patients early and being aggressive, this is just one more example to support that. Now, it turned out that their biomarker study was a failure part of the study. So it turns out we really can't really identify a particular group because whether you are at high risk by biomarkers and genetic testing or low risk by biomarkers and genetic testing, it turned out that more aggressive therapy is the way to go. So what should our aggressive therapy be? Well, let's just go through a quick case. Dr. Al-Katabi always teases me. I always start with a case. This is a 32-year-old female presented to our GI clinic from the emergency department in London a few years ago. She was diagnosed actually 8 years ago elsewhere at the age of 24 with ileoclonic Crohn's disease. Had some high-risk features, a cigarette smoker, and relevant here is she was of South Asian descent. She had received prednisone about 8 years ago early in her disease. She had been put on adalimumab for a couple of years, but then either lost response or lost interest, it was hard to say, and went to a naturopath for a number of years until she presented to our emergency department. When she presented to the emergency room, she had a 6-week history of right lower quadrant pain, diarrhea up to 6 times per day, fatigue, some arthralgias, anorexia with a bit of weight loss. She was underweight, had some mouth ulcers, had some tenderness in the right lower quadrant, and no evidence of any perianal disease. So a very kind of typical case. Had some blood work, as you'd expect, that showed a mild anemia, positive inflammatory markers, nothing that looked otherwise rheumatic. Tested her for infection, and the CT did show some evidence of terminal ileal disease without obstruction. And here was her scope. This was after a couple of weeks of steroids that were given by the emergency room physician. She had some active disease in her terminal ileum. You can see some ulceration there, and in the right colon as well, with some ulceration and evidence of chronicity. For those of you that use the SCS-CD, I would probably give the left side a 6 and the right side a 5, so a total of about 11. So one of those patients that would definitely fit in some of our trials of biologics that we'll talk about a little bit later today. When she was seen in clinic, her CRP was down a little bit. She had a positive fecal calprotectin. We continued the prednisone, and then this was a few years ago. We were sort of considering azathioprine and sent her to our personalized medicine clinic. Now, there's probably over 50 papers of azathioprine in Crohn's disease. When I kind of tease the residents and some of our fellows, I often try to get them to remember a couple of them. I find this one is probably the best paper, and because it's Spanish and has the word Aztec in it, it's probably a good one to remember. And I think it illustrates a couple of things. I mean, when people use, people who used to love azathioprine would often say, well, you didn't use enough, or you didn't use it early enough. And so this was a study designed where they got patients all within 8 weeks of diagnosis. They randomized them to azathioprine and placebo. About a little less than half were male, and most were on corticosteroids. There was no previous history of treatment, and they used enough. They used the full, almost scary dose of 2.5 milligrams per kilogram. And the primary outcome measure was corticosteroid-free remission at 1.5 years. So, my God, if you're going to use it this early, and you're going to use this much, and you're going to give it 1.5 years to work, surely if azathioprine's ever going to work, this should be when it works. And the bottom line was, if you can look at it, is it didn't really work. So in terms of remission, there was no clinically significant difference. In terms of steroid use, no clinically significant difference. But there were more side effects. So we did see leukopenia and pancreatitis at rates that were, as high as 20% for leukopenia and as high as about 8% for pancreatitis. So certainly these are side effects we'd have to deal with. So you'd say, well, should we ever use azathioprine? Well, I mean, if you ever wanted to, on your Royal College exams in Canada, if you ever wanted to talk about induction for severe Crohn's disease, you at least have to be aware that, the gold standard in the old days was SONIC, right? And this is the SONIC trial, and we all remember the graph on the left where combined infliximab and azathioprine was superior to either agent alone. But this is stuff that was sort of more in the appendix. And if you look at why that is, like why did azathioprine help infliximab? Well, it probably is mostly explained by the next two panels. If you were on azathioprine, you were 14% less likely to have antibodies at 30 weeks. This is early on. And your medium trough level of drug was well over double. Okay, now these trough levels are kind of low. We didn't measure trough levels routinely back in 2007, 2008. We certainly do at times now. And you can see here that azathioprine did help the drug to work better. Just to show you that this isn't unique to azathioprine, the Japanese Diamond trial showed a similar thing. This was kind of like SONIC with adalimumab. And at 52 weeks of follow-up, primary outcome measure was both endoscopic and clinical. And what you can see here is that even though azathioprine didn't add much on the clinical remission side, there was a definite trend, if not statistically significant difference in terms of endoscopic improvement. But why was that difference? Well, that difference was really because the trough levels were higher by about 7.56 versus 6.5 in the patients who received azathioprine with their adalimumab, and the rate of antibody formation was also less as well. So, and then finally the SPARE trial. So do we have to use azathioprine forever? So if you're going to go with a combined immunosuppression, and my talk is heading towards perhaps not being a routine administrative technique, But the SPARE trial does tell us if you're going to use it, you probably don't have to use it forever. So this trial was published a couple of years ago, a year and a half ago. It was a multi-center, open-label trial, randomized withdrawal. They took patients who were doing, doing very well on combined therapy with infliximab and azathioprine or methotrexate, and they randomized them to either continuing both, stopping the immunomodulator, or stopping the infliximab. And you can see here with the 2-year follow-up, you had, in terms of patients that continued on with combo, they lost them at a rate of about 6% per year, kind of what you might expect with our patients who are doing well. If they stopped the immunomodulator, it really wasn't any different whatsoever. In fact, it was numerically a little bit lower, so it seems to be safe to stop. But obviously, if you stop the advanced therapy, stop the infliximab, that's where you tended to run into trouble. So I think if you're going to use azathioprine, you're not using it as monotherapy. You may consider it in your more severe patients who are on anti-TNF therapy. And if you're going to use it, the good news is you don't have to use it forever. But if you're going to use it, do you do genetic testing? And this is one of these tests. It's not a very complicated test. It's been around for a lot of years. TPMT testing. I'm not going to talk about it today in any sort of detail. We do it routinely in London. It may not be available everywhere, but certainly it's something that's recommended by a number of guidelines. But what about other things other than TPMT? If you've ever done TPMT testing, I'll bet you've had a patient who was a normal metabolizer and still got leukopenic. And why is that? Okay. Well, this is an enzyme that called Nudix hydrolase, and the gene for it is NUD-T15. And NUD-T15 is something that's only been discovered recently, something we've been very interested in, something we've done a few studies on. And it was actually one of the abstracts that was an oral at ECHO. And you can see here, this is the diagram that we all have to memorize for our exams if we're, or if we're getting quizzed in clinic, that we look at the metabolism and how the active agent is 6-thioguanine. And what we're trying to do is keep that level adequate without leading to toxicity. And if you have drugs that inhibit an enzyme called xanthine oxidase, you can run into trouble, and that's things, allopurinol and those kind of drugs for gout. If we have patients that are deficient in TPMT, that's important as well. But if you're deficient in NUD-T15, you also end up with higher levels of 6-TG that can be potentially toxic. And this was, we do routinely measure this in patients of South Asian descent because it is much more common in that population. And this was an abstract from ECHO last year. It was the UK group looked at 23,000 patients that tested specifically for NUD-T15. And you saw that in the general population in Britain, the overall rate of NUD-T15 deficiency was rather low at 1.3%. But in patients of South Asian descent, it was 11.7%, so it's significant. And if you're ever going to get into measuring some enzymes for azathioprine use or some of the other things we're going to talk about in a few minutes, in this particular population, I think that's significant. And now, if it's common, is it clinically significant? And this is the same abstract. And essentially what they did was they took the 451 patients that they found out of the 23,000 who had who were deficient in NUD-T15. They matched them to 916 control patients, and they excluded anybody who was TPMT deficient. Remember, this was a real-world sort of retrospective study, so they didn't control the thiopurine dose, but the average dose was 1.8 kilograms. And you can see here that myelosuppression was definitely more common in patients who were NUD-T15 deficient. So any myelosuppression, you are 3 times more likely. Now, their definition of myelosuppression with less than 2 neutrophils is probably a little bit on the conservative side, but it was still common. Severe myelosuppression is a number I think we would all get worried about if the neutrophil count was less than 1.0. And hospitalization for related neutropenic sepsis was again more significant. So if you're going to go so far as to measure TPMT, certainly in a certain populations, measuring NUD-T15 might be relevant as well. Now, what else? Remember on that initial Aztec trial over on the right side, we had a higher incidence of pancreatitis. It turns out you could predict that as well. And there's a certain gene, an HLA-DQA1 gene with a polymorphism. And remember, when we use the word variant, we usually mean bad. When we use the word wild, we mean good. And if you're a wild patient, a wild gene, an AA gene, your overall risk of pancreatitis is pretty low at about 0.5%. If you have one copy of the variant, your risk of pancreatitis is 4%. And if you have two copies of the variant, in this study that we did in London, it was about 15%. So we always tack this on as well at any patient who's going to start on azathioprine. So let's get away from a drug we don't use very much to a drug we use a lot, and that's anti-TNFs. And people might be familiar with this to a degree. I think if you're reading, if you read the PANTS trial, it's a large British cohort with 1,610 patients, all who are getting either adalimumab or infliximab. And in the PANTS trial there's a lot of words in the PANTS trial, but there's a lot of interesting stuff. And if you read it, you could probably make 2 or 3 talks just about some of the observations they had in the PANTS trial. And I find it interesting partly because, and this is a trial done, a couple years before COVID, that in Britain about 60%, so over half the patients on anti-TNF therapy were receiving a concurrent immunomodulatory therapy. The vast majority were receiving azathioprine or 6-MP, about 52%. 6% received methotrexate. And it turns out, as expected, as we saw in the SONIC trial, that taking an immunomodulator is protective against antibodies. Now, the antibody rates here, you'd say, well, they're incredibly high here, and these are actually a drug-tolerant assay that's been used. And drug-tolerant assays are great because you can measure antibodies with a lot of sensitivity. But they do have a little bit of a specificity problem because many of these antibodies you find are not actually drug neutralizing. So take it for what it's worth, but whenever you're reading a trial about antibody rates, always try to figure out whether that trial is using a drug tolerant or the more common drug intolerant assay. And you can see here on the left-hand side, this is just the infliximab versus adalimumab and overall remission rates of 35 to 40%. But you can see that the antibody rates for both infliximab and adalimumab were very significant, although a little bit lower for adalimumab, perhaps because of the molecular structure, or on the other hand, perhaps because of the more frequent subcutaneous administration cycle. But what did they find in the PANTS consortium? They actually did the HLA-DQA1 testing, and they looked at the patients with wild type and the patients who are variants. So the wild type patients are less likely to get antibodies, and the variant carriers are more likely to get antibodies. And when you look at our graphs that we're going to look at today, they're actually kind of reverse negative. So the good thing is to be higher, and the bad thing is to be a little bit lower. So the y-axis says percent of patients with no anti-drug antibodies. And if you are a variant carrier of even one copy of the HLA-DQA *01, 1 or 2, but even one copy, you are much more likely to get antibodies over subsequent months. Now, we looked at this. This is one of the reasons why I'm presenting it. This is a paper that I was a helper with my colleague Dr. Wilson and Dr. Kim. And this is when we looked at our own population. So remember I showed you our original study there of azathioprine and pancreatitis with about 900 patients. We store all that serum, and we've got consent from all the patients to test for future interesting genetic findings. And we found 262 patients that in that cohort that had significant enough follow-up on infliximab to actually see how they did. And we did HLA-DQA1 *05 testing, looking for both wild and variant. And essentially what we found was exactly what they found in the PANTS trial, and that is that wild type is about 60%, but about 40% of our patients are variant carriers. 40% of our patients are genetically primed, produced antibodies to anti-TNF therapy. And if if you're genetically primed for that, you can see that you're in the blue curve. This is percentage of patients who are antibody free at the end of the study, and we're talking about 200 months in some cases. Most of our wild type patients did not get antibodies, but most of our the majority of our patients with the variant did get antibodies. And was that clinically significant? Well, yes. On the right panel, you can see that treatment discontinuation was much more common if you were a variant carrier, and loss of response was much more common if you were a variant carrier. So now do you say to yourself, well, if we know that ahead of time, at that time we didn't really have a lot of other modes of action, but of course now we do. Maybe use a different MOA. We'll talk about that today and a little bit later in this talk. But it's because you're more likely to lose response to drug. If you're a variant, you're more likely to lose response to your anti-TNF therapy. Now, other than using a different MOA, is there any other strategy? Well, there kind of is. I mean, if you're a wild type sensitizer with low risk of sensitization, you can see here it probably makes no difference whatsoever whether you subject the patient to the risk of azathioprine or methotrexate. So essentially, you don't have to worry about all that TPMT, NUD-T15 testing I just talked about. But if you're a variant patient and you really want to still go with an anti-TNF, those are the patients that you can see that combination therapy produced a benefit of about 12 to 15% more in those situations. So I guess I'd make the argument here that the only patients that really need combination therapy are the patients, the 40% of your patients that are higher risk of sensitization. Now, does this apply to the new drugs? I mean, we're all here because, we've been, had anti-TNF for 17, 18 years now. We're all familiar with anti-TNF. We all have our own strategies, but we're all starting to use medications with a different MOA. And this was another abstract that was presented at ECHO a few months ago. And this was a Spanish working group. I wasn't actually that familiar with them, but they're kind of like the Spanish version of Jetaid. And they looked at clinical outcomes in patients treated with ustekinumab, and they went back just like we did and did HLA-DQA1 star 05 testing. They can actually do it on a salivary sample. And what they found was they had 204 patients with Crohn's disease. 96% of the patients had previous biologic therapy. The median follow-up was 417 days, and about 25% of these patients had acceleration of their ustekinumab dose. And again, what they found was amazing. Just like everyone else, about 60%, in this case 57% of our patients are a wild type, so at low risk of sensitization, and about 40%, in this case 43% of patients, were variants at higher risk. But they found at the end of the day, no difference in loss of response. So it probably turns out that everything I told you a few minutes ago only matters in anti-TNF therapy. It probably does not matter in medications with a different MOA, particularly our IL-23s and IL-12s. So I put this up. These are always really hard. When you're doing a talk, you want to finish off with a nice flow algorithm, and you keep playing around with it, and you think it's going to be simple, and then you got arrows going up and down and all around, But this is sort of on the top there. You've got the King Fahad strategy with Dr. Ahmad, the biosimilar anti-TNF monotherapy. Governments are paying, and that's what we do in Ontario. It's adalimumab and infliximab are less expensive now, and the governments want us to use these as first-line therapies because they're less expensive. And then we have the
Salama Hospital, like Dr. Al-Katabi's hospital, where they prefer to use perhaps the alternative MOAs, the early onset, early use of IL-12/23s, and going forward IL-23s, JAK inhibitors, and anti-integrin therapy. And if you aren't really very interested in personalized medicine, can't get it, or really think my whole talk's not even that useful, just go with the right hand square, okay? And you don't have to worry about it. But if you're in a situation where you really like anti-TNF therapy, you don't really like immunomodulatory therapy that much, with or without genetic testing, if you start with anti-TNF therapy, you can either, if you have availability of genetic testing, pre-testing, personalized medicine testing, you can either do it before, or perhaps before you try it again. And this is sort of like the ship, the Vasa. You can, get it all out. You can do everything before, make sure it's going to float, or you can take your chances and see if it sinks in the harbor a few days, within a few hours of launch. But if you go with your anti-TNF monotherapy and you have a patient who has secondary loss of response, and you're considering another anti-TNF, and you're considering using an immunomodulatory therapy, I think this is the best patient to send for personalized medicine. And these are the ones that I always do. And we'll test for TPMT and NUD-T15 because we may want to use immunomodulator. And we'll test for wild and variant types of DQA1 star 05. We also test for risk of pancreatitis with DRB1. And essentially there's kind of three things that could happen. On the left side of the panel here, you could be a variant for azathioprine. You could either be a slow metabolizer through TPMT or NUD-T15, or be at higher risk of pancreatitis. And if you're going to pull out your second anti-TNF, maybe they have fistulizing disease or something, you're not going to use azathioprine. You're either going to use nothing or consider methotrexate with your second biosimilar. If you're wild type and you're not at risk of it, then that might be a good patient to use azathioprine with your second biosimilar and pull out the stuff we showed you from Diamond and the Sonic. But if you have those patients and you're a variant for DQA star 05, those are people you have to follow very carefully. And I know, depending on the area, there's different access to proactive TDM, but these are the patients I do proactive TBM. And then finally, if you haven't already started with your different MOA, if you haven't already started with your IL-12/23, your JAK, your anti-integrin, your IL-23 specific agent, and you're unlucky enough to not be a good candidate for azathioprine, and if you're in the 40% of patients that are high risk for sensitization, those are patients that even in tough jurisdictions like where I come from, we could almost always get coverage for early use of an alternative MOA. So thank you very much for your attention. This is a talk that I wasn't sure I was going to be given today initially, because when I was invited to speak, there was some talk of perhaps talking about some newer agents, but we weren't sure about approvals. But because Tremfya, guselkumab, has now been approved for the treatment of both ulcerative colitis and Crohn's disease, I believe in the United States and in the Kingdom. I think you're in the first two countries to get it approved. We get to talk about this new advance today. So I've certainly looked at all these slides. I've moved them all around. I've examined them intensively, and I certainly I do approve them. Although I have received an honorarium for this talk today. So, despite advances in IBD management, there's still a lot of burden for patients. And I mean, over the slide here, we talk about a quarter of our patients progress to more extensive disease. I was at University Abdulaziz Hospital on Wednesday, and certainly it seemed like more than a quarter of them had very advanced disease. You have very complicated patients. I was warned by John Marshall and a few other people about how tricky some of the cases are, and I commend the IBDologists here and Dr. Mosley in particular for having such a wonderful group at providing such excellent care. Patients, of course, have more than just intestinal disease. They have extraintestinal disease as well. We have a lot of treatments, and I've just talked about effective treatments, but as you can see, it's hard to break through that therapeutic ceiling of 40% kind of complete healing. So many times we're left with patients who either don't respond, patients that respond incompletely, or patients who respond well but then recur. So clearly we need more options. We also need options that potentially treat some of our extraintestinal manifestations, and some of our treatments like anti-TNFs and even traditional IL-12/23s are very effective for this. I mean, the one drug that we use often in ulcerative colitis, perhaps less often in Crohn's disease, and Entyvio is not effective for these really in any way. But many of our agents do have some improvement in terms of arthritis or spondyloarthropathy, even uveitis and ocular manifestations. So we have to kind of keep that in mind when we're treating patients as well. But the thing that's been kind of pounded into us, if you go to any international meeting, particularly in Europe, you go to ECHO, you go to UEGW, they always talk about the STRIDE guidelines. And the STRIDE guidelines are very important. They're very aspirational, but I defy anyone in the audience to think that they can be universally adhered to. They're not they are difficult and very aspirational goals for our patients. I mean, ultimately, the first goal I think makes sense is that we want patients in symptomatic response. So we want to start a patient on a therapy, and we want to see within a week or 2 weeks or a month or certainly no longer than 3 months, we want to see the patient feeling a little bit better. And then ideally we want to see improvement in their biomarkers, and biomarkers are fairly easy to get. C-reactive proteins are just a blood test, of course. Not every patient likes to collect their stools for fecal calprotectin, but that can be a very useful test as well. And then ultimately we've been encouraged to seek endoscopic healing. And I spoke a little bit at King Fahd Hospital yesterday about the correlation between endoscopic healing, symptomatic stability, and perhaps even more importantly, the avoidance of hospitalization and surgery. So I think the STRIDE guidelines are on good grounds here to within 6 months, or you're going to see data today on 48 weeks, getting some degree, if not complete, endoscopic healing of both ulcerative colitis and Crohn's disease. In Crohn's disease, we talk about transmural healing, and there's been more and more data on the role of not just endoscopy, but cross-sectional imaging, on ultrasound, looking at these patients. And in ulcerative colitis, I'm always kind of glad to see this, because I was always one that liked to take a few biopsies of the rectal sigmoid and quiz the residents on what their favorite histologic index is. And I think it's becoming more and more relevant, histologic healing, and this idea of HEMR that you'll see in studies, which is histologic and endoscopic mucosal remission in ulcerative colitis. So what do we have? Well, we said this was going to be a talk that's going to focus on new molecules. Probably the newest, some of the newest molecules we have, certainly in Crohn's disease, are specific IL-23 antibodies, and of course there's 3 of them. There's mirikizumab or OMVO, which is IL-23 specific. And it's approved in ulcerative colitis. We have risankizumab or Skyrizi, which similarly is IL-23 specific. And finally, the new kid on the block, guselkumab or Tremfya, which again is IL-23 specific. And you can see that these are IL-23 specific because they bind to the P19 antigen. And if you want to sound kind of trendy in this kind of MOA field, perhaps you say it's a P19 world, for example. And we don't really know that for sure, but there's increasing evidence that I'm going to show you in a few minutes that probably is the case, that P19 specificity without the blockade of IL-23 is superior. So what else is the difference between these antibodies? Well, between mirikizumab and risankizumab, you've got the fact that one's IgG1 and one's IgG4. You know, whenever I'm in the audience, like you guys, and listening to the experts talk, I try to discern whether anyone really cares whether it's 1 or 4, and it doesn't sound like they do. But there is this little bit about guselkumab that is a more humanized antibody. It sounds like we're going back to adalimumab again when we talk about that. But it's more humanized, and it also has, because of that, and because of its FC domain, it does have a little bit of a different mechanism of action. And, you know, when I talk to some of my colleagues in Canada, some of them who are very busy clinically, some of whom are very busy on the research side, many of them are very interested in these slight differences of MOA, and some of them perhaps are just more interested in the final data. But we have our little cartoon here of Tremfya. And essentially, when you're giving a monoclonal antibody, the easiest way we conceptualize it is that these antibodies kind of float around your serum and inactivate the cytokines that are driving the production of other cytokines, and be it, you know, and probably the IL-17 pathway, which is driven heavily by IL-23, is a very important, well, it's clearly a very important mechanism of action. And when you actually give a drug like Tremfya, you actually mop up IL-23 in your circulation. But what's a little bit different about Tremfya is its FC domain also binds to the CD64 receptor on the monocyte to reduce the production of IL-23 as well. So if you think it's important to not only block all the IL-23 that's floating around, but also to pick it off before it can even be produced, that might be a conceptual reason of, you know, making this a little more interesting. I mean, one of the analogies I use, I don't know how many people in the audience are old enough to remember, but, you know, when infliximab came out and then adalimumab came out, you know, we thought Enbrel, right? We thought Enbrel was going to work in Crohn's disease. But Enbrel mediates anti-TNF in a little bit different way, and it doesn't work in Crohn's disease. It works great in rheumatoid arthritis, but it doesn't work in Crohn's disease. And so, you know, I would use that as an example of why MOA may matter a little bit. And MOA matters if you look on the right side of this graph and the left side of this graph. This is kind of some in vitro information that's not directly related, it hasn't been proven to work in you know, the clinical setting yet. But if you give risankizumab or guselkumab in a test tube, they both neutralize circulating IL-23 exactly the same. But if you give it in a monocyte culture, okay, you actually get less IL-23 production as generated by by the blue graph that's a little bit below the other two. So essentially, what you see with guselkumab that's a little bit different is that circulating IL-23, they're equally potent, but in terms of producing IL-23 at the level of the monocyte, it works through, there is less of that, and it's probably through its binding to CD64. And, you know, I wandered by the Johnson & Johnson, I wandered by all the booths, but I wandered by the Johnson & Johnson booth, and certainly the CD64 story is something that they're allowed to mention. Okay, so now we've got our IL-23 specific, our P19 drugs. You know, what's our, why do we need more drugs? Well, I think we all know in the audience that we have mucosal inflammation that's causing symptoms. It's causing complications. We know that the STRIDE-2 guidelines tell us that we want to heal patients. And so therefore, we want studies out there that not only show that we can put patients into remission, okay, but that we can also keep patients in remission, and keep them away from complications. So let's start with UC. UC is a little easier to monitor, studies a little easier to do. You know, we all do flex SIGs, we can all take biopsies, we can usually assess all the disease we care about. We have a Mayo score that's understandable, that can help us determine how well patients are doing. And with Quasar, they did a study design that should be very familiar to all of us. We give a placebo, we give the active drug, we induce remission, we take the patients, we re-randomize them, and we see how they do over the next year. So you're sort of, you're killing two birds with one stone. You're getting your induction information and you're getting your maintenance information all at once. And of course, with your inductions, the doses tend to be higher. Interestingly, with Tremfya, they're not actually that much higher than the maintenance doses as opposed to some of the other drugs that we use. And in terms of maintenance, you can see two main doses, one every month, 200 milligrams every 4 weeks, and one every 8 weeks, perhaps a little bit more like Stelara with a slightly lower dose. And then, of course, a placebo arm. And if you look at the actual ability to put patients into clinical remission quickly, and by clinical remission, we're talking about modified Mayo scores of 2 with no rectal bleeding whatsoever. Remember, the modified Mayo score gets rid of the SGA, or sufficient global assessment. So when you see a study that has a modified Mayo score, you're actually talking about a ceiling of 9 as opposed to a ceiling of 12. You can see that you get, you know, rapid clinical remission, okay, and also long-term clinical remission. And you know, the long-term clinical remission didn't just apply to the patients that went into clinical remission. Any patient that actually improved was going into that study. And you can see here that Tremfya at both doses was highly effective, much greater than placebo for both for maintaining clinical remission over almost 44 weeks. Now, one of the things that happens to us all, I mean, I'm a busy clinician like everyone else in the audience. I had my massive clinic on Friday in the middle of a snowstorm. Somehow patients still made it. We have snow in Canada right now. This is such a treat being in Jenna. I've got to thank you guys so much. I'm leaving my wife to shovel out the driveway. I'll make it up to her when I get back, don't worry. I bought some nice gifts. Anyway, you can see that we get early response. So we don't want patients calling us up after a couple of weeks who aren't feeling any better at all or aren't seeing any improvement. And you can see here that as early as the first week, after that first 200 milligram induction dose, you can see improvement, okay? And that improvement in terms of symptomatic response applies to almost 3/4 of our patients by week 12. So that's pretty good. So, you could argue that, you see 23%, that's not that great, but I mean, 23%, that's like remission. When you're talking about improvement, and I think at week 12, even the STRIDE guidelines don't expect us to put everyone into complete remission. At 12 weeks, we're happy with significant symptomatic, and to some degree mucosal response. You can see that the Tremfya induction at 200 milligrams every 4 weeks is highly effective over placebo. Now, one of the things that's sort of been a little bit of something we make observations. We do a lot of flexible sigmoidoscopies in our IBD clinic, and we often, we're always arguing about Mayo 0 versus Mayo 1. I think we all know Mayo 0 when we see it. All right, there's some Mayo 1s out there that we'd like to call Mayo 0, but we know the central reader in the study won't let us call it Mayo 0 because the vascular pattern is just a little fuzzy. But Mayo 0 ideally is what we should be striving for. And one could even argue in all the original studies of ulcerative colitis that, is Mayo 1, or at least not every Mayo 1 is truly remission. So in terms of Tremfya, they do have some really good data on Mayo 0. In terms of the overall population, at 1 year, you had 34% whose bowels had completely normalized, beautiful vascular pattern, no inflammation whatsoever. And that number, is even higher at 42% in patients in whom this is first-line therapy. And, even, reasonable, I guess, if you consider Mayo Zero a very aspirational goal in patients that are bio-IR or who have previously failed biologics or JAK inhibitors. Kind of a nasty looking bowel at week 0. This was called Mayo Score 3. I have to admit, this isn't the worst. I mean, we've all seen much worse than this. I think this is one of those examples of, why didn't they have a Mayo Score of 4? Because there's, I always figure if I'm too scared to put the scope past the sigmoid colon, it's more than a 3. They wish there was a 4. But anyway, and this is the kind of, complete healing you can see with Mayo Zero. All right, and then when patients are in clinical remission at 1 year, about 60%, so if you have a patient who is in clinical remission, who's feeling perfectly well, actually the vast majority will actually be a Mayo Zero. So 67% of the patients who are in clinical remission at 1 year were actually in that Mayo Zero category. And I do think someday we'll be there. Well, Mayo Zero is going to be our goal. So we have a few case studies. The cases I brought with me, and some of the cases we have at the booth later this afternoon are sort of cases I brought from London. But this is some cases that were relevant to physicians and that Johnson & Johnson were working with when they came up with this. And this is a gentleman, Mohammed, and he is a very healthy looking, active professional. He's got moderately active ulcerative colitis that was diagnosed recently, okay? And he's having 3 to 4 bowel movements per day. He does have some rectal bleeding, we'll say 50% of the time. He has active inflammation by his fecal calprotectin of 1251. He's got C-reactive protein that's still within, not over that sort of 5 threshold, but certainly significant. And he's got left-sided colitis. And he's failed budesonide. He's currently taking mesalamine, and he's on his 2nd course of prednisone in his 6-month period. Now, I don't know about you guys, but I love these patients, okay? This is the kind of patient that the world is my oyster. We could do anything we wanted on this case, okay? We could pick whatever. I know what you'd pick, but we'll talk about that later. We've got a little bit of, an issue, a little bit of Mohammed's story. And I think when we know there are some patients that have these kind of symptoms and don't really complain very much, okay? And they're getting by. But, and then there's other patients, it severely affects their quality of life. And I would argue, I think we need to heal both these patients, but this patient is missing out on what he likes to do. He's going to the bathroom all the time, but he's been a little bit hesitant about the word biologic. He sounds a little bit scary. He doesn't want to commit to something that he has to go for regular infusions for the rest of his life. He doesn't want to feel sick, and he'd like to get better with something, and he certainly wants something safe. So what do we just sort of look? So we have a patient here that we could use anything, and is Tremfya guselkumab a good choice for him? Well, he wants to feel better. That's his goal, his first goal. And he wants to feel better pretty quickly. Maybe he's got another fishing trip coming up. And you can see here that there's a more than a 1 in 3 chance he'll be asymptomatic, he'll have a response at week 2. By week 4, we can see that, about 60% chance. And this is a patient that by week 12, we'd be surprised when he came back if he wasn't better. Okay, I mean, it happens, but there's like an 82% chance that we'll go see him in the room and he'll be really happy. Now, whether we scope him at 12 weeks, do a colonoscopy, a quick flex sig, or perhaps leave him a little bit longer, I'd probably argue leave him a little bit longer if he's feeling this well. But whether we would see complete HEMR, which histologic endoscopic mucosal remission, is debatable. But the bottom line here is this guy should be in steroid-free, with a good, solid clinical response by 12 weeks. And you'll have done him a big favor in terms of his quality of life, his future prognosis, and his need for recurrent courses of prednisone. So this would be a great case. And of course, will he stay well? Yes, he will. I mean, the odds we just showed you, the odds of him having a perfectly normal bowel when you scope him at week 44 are very significant. And of course, if you include Mayo 1 in success, it's even going to be much higher than that. And this is just a slide that when you're in clinical remission at 1 year, 71% were in endoscopic remission. So the patients that feel well are much more likely to have Mayo 0 than patients who don't feel well, and not overall surprising. So again, we can ask if there's any questions, but we can, I guess we'll leave them for the end. This is Sarah. She's a travel blogger. And they still have bloggers. I guess they do. It's with all our the way social media goes. These terms keep. I thought it was TikTokers or something like that she would have. But she's a travel blogger. She's obviously that's very important for her. So that any effects on her quality of life in terms of her not only her enjoyment but her job would be very significant. She averages 4 to 5 daily bowel movements. She has moderate rectal bleeding. She has pancolitis. So even though left-sided colitis patients perhaps a third of the time can go on and get pancolitis, the patients with pancolitis, I think, raise our antenna a little bit more. We're a little bit more concerned. And this patient's actually had severe disease, like I just showed you. She's had some improvement with current therapy, but she does have persistent severe inflammation. Her biomarkers are very positive. Her fecal cal 1600 or CRP 7.8. And she's failed conventional therapy, including an anti-TNF with adequate drug levels. And I really haven't, I guess I haven't had a chance to ask a lot about drug levels. I think Dr. Ahmad mentioned that they're not really that easy to get in the public sphere, but certainly in Canada, in the days when anti-TNFs were all we had, we would definitely monitor drug levels and push them to a point where before we said a patient was failing, that they were actually helpful. So I will go into to the right side. I think it's just sort of the iteration of what I said, how this is affecting your quality of life. And you can see here that this is pretty interesting as well. You'd think that having failed infliximab, that she would be a tough one to treat with an IL-23, but indeed, there's a very good chance that we can get her better, okay? And this is probably where we're gonna be kind of thinking, is this the patient that we would use more vedolizumab, or is this patient we're going to go more with IL-23? And I really think the world is sort of heading in a bit of an IL-23 direction in this sense. And you can see with Tremfya, the numbers aren't quite as good as bio-naive, but pretty solid. We're talking, double the early response compared to placebo, 30 versus 15%. And by week 12, there's a 61% chance she's going to be feeling better and thanking you for it. And in terms of getting to Mayo 0, probably in her with Mayo 3 pancolitis, that bowel may never look perfectly normal, even if the histology looks normal. But you still have a chance of getting her to Mayo 0. And of course, your chances of getting to Mayo 0, your chances of seeing Mayo 0, I guess, are much higher in a patient with no complaints as opposed to a patient who's still having symptoms. Okay. Now what about, why are IL-23s getting so popular? Well, their administration schedule perhaps is more favorable. There's less in the way of therapeutic drug monitoring we have to worry about. We definitely get less sensitization, and they work pretty quick. And I think the story that the immunologists tell us that IL-23 is a major driver of the inflammation in our patients. I think all those things make these drugs very appealing. But probably the thing that makes them the most appealing is the fact that they're so well tolerated. And you can see that really the only side effect that that is perhaps more significant than placebo is some, mild upper respiratory tract infections, but none of the things we really worry about, like sepsis or even malignancy, really occur. And we're going to talk a little bit. I think Mashari's got some cases for us later, and we're going to talk a little bit about the safety of some of our choices if patients need to go for even intestinal or non-intestinal surgery. So bottom line here is that this class of drugs is very safe in ulcerative colitis and works well and works reasonably quickly, and that the dose is fairly simple with 200 Q4 for IV for ulcerative colitis, and then a choice of either Q8 or Q4 going forward for maintenance. All right, so we're going to switch now to Crohn's disease. And again, it's not often you get a drug that is approved for both indications at the same time. So I think that's going to be very appealing because, as we all know, we have about 10% of our patients, we're not even sure which one they've got. We were at Mahmoud's multidisciplinary rounds on Wednesday, and between the pathologist and the radiologist, I think 2 out of the 5 cases, we were hunting granulomas, we were checking disease extent, we were checking continuity, looking at fistulas, trying to decide. And I guess one of the appealing things here is that when this drug becomes available, you've got both indications. So this is a patient with Faisal. He's got moderately severe active Crohn's disease, diagnosed 6 years ago. He's got 6 to 8 bowel movements per day. He's got a fecal calprotectin of 1124, a bit of a higher CRP. He's got both ileocolonic disease. So remember I showed you my case I had earlier with that SCS-CD of 11. Faisal's a little bit more with an SCS-CD of 14. For those of you who don't really calculate it or care about it very much, generally in some of the studies of milder disease like CView, we would see SCS-CDs in the 7 to 9 range. In most of the studies you're going to read going forward in Crohn's disease, whether it's Skyrizi or whether it's Tremfya or any of the other drugs, you're going to usually see SCS-CDs of around 14 as the mean. Of course, sicker and not as sick, but turns out by coincidence that Faisal's about a 14. And he's failed immunomodulators, he's failed prednisone, and on the right-hand side, if you peruse that, you could expect that this would have a significant effect on his quality of life. So we've just talked about Quasar. Now we're going to talk about Galaxy 2 and 3. And you don't really have to, get too excited about 2 and 3. Remember pharmaceutical companies need, at least in North America, they need 2 studies to get approval. I'm sure it's the same here. And so they usually run them in parallel. So, and then tend to combine the results. And Galaxy 2 and 3 was a very, very ambitious, and I would argue a very, very satisfying study design for the Avlish Commission. What they did was they compared two doses of induction with guselkumab, 200 milligrams every 4 weeks, just like we saw in ulcerative colitis. And then one of the groups got the same maintenance of 200 Q4 sub-Q, and the other one got 100 Q8, just like in ulcerative colitis. And then they added in an ustekinumab arm for comparison. And on top of that, they had a placebo, which they needed. But then anybody who failed placebo then got flipped over into ustekinumab. So you were able to compare, you were able to get a placebo group, an ustekinumab group, and then for maintenance later on, you were able to look at a larger group of ustekinumab because the patients who had failed placebo got to go into that group. And they had the usual outcomes. But what's the most interesting thing about this trial, and it is similar to Sequence, right? You guys, everyone, a year and a half ago or 15 months ago, Sequence made a big stir because, it compared to an active comparator in Crohn's disease, but also it's a treat-through design. So instead of like Quasar, like some of the previous studies where you do an induction trial and then you re-randomize, this is more like the way we treat our patients. Like, we don't induce our patients and then say, oh, come back and see me in 12 weeks and we'll decide whether we're going to continue or not, right? We don't do that. We book them for their maintenance treatments, and that's exactly what was done in Galaxy 2 or 3. And so what kind of patients got in this? Well, these are moderately severe Crohn's disease patients. You know, you're always looking for a CDI score on the, you know, touching 300. That's exactly what we've got here. An SCS-CD score in that 13, kind of the 14 sort of range is really common. And it is important that you look at ileal disease. I think, you know, it's generally accepted by all of us that the ileum's a trickier place to heal. The ileum is a smaller tube, so when you get a problem in the ileum, you're more likely to get an obstruction. If you get an obstruction, you're more likely to get a fistula and an abscess or end up with a stricture and surgery. So having a significant number of ileal disease patients are important, and even though we've only outlined the ileum-only patients, you can see that 60% of the patients actually really had ileal disease, because there was people with ileum and colon as well. So they weren't just treating the easy sort of colonic patients. And again, about 50-50 had been exposed to biologics, and what they use the word bio-IR. And I'll bet you if you'd polled me a few months ago, I always, like, all their bio-failure terminology, but bio-IR just stands for inadequate response. So if you see bio-IR, you can think of kind of bio-failure, but basically patients that hadn't responded well. And I think it's actually a good term, and it'll start rolling off my tongue eventually. And of course, most of these patients had failed anti-TNFs. Just a few had failed vedolizumab overall. And at the time of, most of these patients, of course, had corticosteroids, but at the time of randomization, 40% of them were receiving it, and about a slightly smaller number were receiving an immunomodulator like we talked about earlier. So what are the sort of efficacy results of Galaxy 2 and Galaxy 3? So let's talk about the studies that get drugs improved. So to get a drug improved, it has to beat placebo and it has to induce remission, right? None of us are going to pick a drug that can't beat placebo and doesn't make the patient feel better early on. So if we look on for this study, you had to have clinical response at week 12, and that's a little bit earlier than actually in sequence, right? Sequence was like 6 months. This is like 12 weeks. And then on top of that, you had to be in clinical remission at week 48, and you had to be, and then for the other co-primary endpoint, you had to have endoscopic response. Now you'd argue, what's endoscopic response? Well, a lot of us would say, oh, I can tell endoscopic response when I look at it. That looks better than it used to. But, it's a bit finer than that. I mean, many of you in the audience have probably put patients in clinical trials, and certainly I do. And I decide what I think the SCS-CD is, but what I say doesn't matter. It's what what Brian Fagan's team says in the basement of Alimentive down the street from where I work, because they centrally read all those to assess. And so endoscopic response is a 50% reduction in your SCS-CD numbers. So these patients on average would have had to go from 13 down to 6 or below. And when you look at the data, on the left-hand side, we've got placebo with the two turquoise numbers here. You've got both the Q4 and you've got the 200 Q4 and the 100 Q8 and the 200 Q4 maintenance doses. And the numbers were about the same. And it'll be very interesting to see what you guys, when you guys go to smaller group discussions or have questions for me, and it'll be very interesting in the audience whether people go with, right off the bat, go with the 200 Q4, or they start with the 100 Q8 and use the 200 Q4 for bailout. And that'll be interesting to see what you guys think. But the bottom line is that you had clinical response rates both at week 12 and week 48, so you had to have both to be counted, that were much higher in much higher in both active treatments than placebo. And the same thing applies for the sequence-like number here on the right side, where you've got clinical response at week 12, which is even earlier than sequence, and endoscopic response at week 48. We've got numbers that are probably 7 or 8, 6 or 7 times higher than placebo. What about secondary endpoints? Well, people might like other things. Some people like, well, first of all, the secondary endpoints, let's look at what you really want to hear. Is this drug, do you think this drug is superior to ustekinumab? And if you want the patient's scope to look better at week 48, it's superior. If you want the patient's scope to look completely healed, essentially, at week 48, it's better. If you want the patient to be in clinical remission and endoscopic response, and I would argue that's probably the most important number, okay? If you want deep remission, which means like everything's like completely healed down to 0, all these things show superiority. Now on the right side, you could argue that if you just want the patient to feel better and you don't really care if their bowels is healed, and you're not buying into the fact that the healing leads to less complications, less symptoms down the road, you might argue maybe I could get away with ustekinumab. But basically, I think the world is going in a direction where healing is important, hence our title. And again, safety, I'm not going to sort of harp on that too long, other than to say that it's safe in Crohn's disease, just like it's safe in ulcerative colitis. And that it was very rare to get tuberculosis, although I think it's still important to screen for that ahead of time. Malignancies were virtually unheard of. And probably the most important, when you compare it to some of the other drugs that we use, we're not really worried about cardiovascular events and venous thromboembolus events, right? So this is not, it's not necessarily the complications you cause, right? It's the complications you're blamed for. And so, if you give an anti-TNF and they get an infection, they might blame you. If you give them a JAK and they get a clot, they might blame you. But if you give veto, they never blame you for anything. And I think that's the same with these, with these P19 IL-23s. I really think that the increased risk of infection is almost 0, and there's no signal whatsoever about VTE and MACE. Okay, but last but not least, we're getting to the end, and this is kind of a little cherry on the top of the sundae. Is Faisal's not sure he wants to go with the IV infusion induction. I don't know if you see that. In Canada, I'm told we have one of the best IV infusion networks going. We've got clinics all over the place. They're inside the hospital, but most of them are outside of the hospital. They all have, they have good nurses and patients tend to like it. But there's still something stigmatizing, even in Canada, for going to a clinic and hooking up to an IV. I think your friends think you're going for chemotherapy or something like that, right? So there's a good segment of the population that prefers sub-Q, and in areas like Europe, it's not that easy to get IV infusions. And I think they pretty much all happen in the hospital, and they're full. So there's a real sort of appeal for a good chunk of our patients about subcutaneous induction. And to date, we don't have a lot of data on that, but we do with Tremfya. So with Tremfya, they have something called the Gravity trial. And the Gravity trial was a study of Tremfya with sub-Q induction for Crohn's disease. So right now, there's no studies in ulcerative colitis, but for Crohn's disease, sub-Q induction has been studied. And it's been studied in a somewhat interesting manner. When they give it sub-Q, they actually give double dose for the first 8 weeks. So instead of getting 200 IV every 4, you're getting 400 IV every 4. So that's interesting. And I guess if you're a patient, if you're a doctor that likes to give more drug, you kind of get to give more drug. And then the sort of the usual thing where they have a treat through placebo arm, and then we've got the guselkumab at the 100 Q8 and the 200 Q4. And what they saw there again was the Crohn's duration 7 years, the SCS-CD score maybe 1 point less than the Galaxy trial, but still about the same. And in terms of the patients that had ileal involvement, again, we're still talking about 60%. So we're talking about basically the same population, right, that was in Galaxy 2 and 3. And what they found here was numbers that are just as good. In fact, if you put your, you know, if you don't like to compare across trials, don't hear this. If you don't like network meta-analysis, don't hear this. But in some respects, you could argue that the numbers are incredibly impressive. For example, if you look at gravity versus in placebo for the overall clinical remission at week 12, you've got 56 versus 21. In bio-naive, you've got 49 versus 25. And I've never seen this in a trial before, and it might mean that it's just as good, but incredibly, even in bio-IR patients, symptomatic clinical remission was 60% in patients that had failed a previous biologic. Now, if you look at endoscopic response, which I've just sort of tried to make a case here that's more important. Indeed, it is easier to heal the bio-naive patients at 48 versus 26 versus the IR patients. So, you know, it depends which one you like better, but the bottom line is that either way you cut it, you can't argue that sub-Q induction doesn't work. And then if you look at sort of the overall outcome, not unexpectedly, for clinical remission at week 48, since it was good at week 12, you can see here excellent numbers for the bio IR at 62%. Again, you know, equal to bio naive, and on the endoscopic response side, again, pretty darn impressive stuff. So these look pretty impressive overall. So what are I think we're at the end of our seminar. Thanks for hanging in with me. You can see that our key learnings is that with Tremfya in Galaxy, you've got 70% of patients got into clinical remission at 1 year, numbers that are starting to perhaps break through that ceiling that we talked about earlier. 1 in 3 patients were in deep remission. And I don't think there's much doubt that even though ustekinumab is a very good drug, that this new era of P19 specific agents, these IL-23 specific agents, are certainly an advance over what we've had previously. Okay, and that's, I believe, it. So if anyone wants to get any more information, please feel free to use the QR code, and I guess we're open for any questions.
Thank you.